Pete, how do I manage vitamin D deficiency in children?
Thank you for your question, Alice. Now we all know you won't get any vitamin D down there, but even in the best daylight Britain has to offer, it's difficult getting your skin enough UVB radiation to maintain your vitamin D levels. As a result, most people in Britain are at least a little bit low in vitamin D. Sadly, this is increasingly being identified in children and adolescents, and this can have a huge impact on their development. So it's vital we learn how we manage this. NICE have produced an excellent clinical knowledge summary on the management of low vitamin D levels in both children and adults. If at all possible, vitamin D should be replaced with colecalciferol, not any of the other forms, because these are either poorly utilised by the body or come pre-activated, carrying a risk of hypercalcemia. Mildly low levels in patients without key risk factors or symptoms can be started on a low-dose maintenance regime. But more severe deficiencies or patients with comorbidities should be started on high-dose regimes, which are called loading regimes. The loading regimes for adults and children are very different, and this is the biggest area of error in vitamin D management. So let's start by going through the adult loading regimes from NICE. Here you can see there's several options available depending on which formulation is preferred at your practice. This allows flexibility depending on what's available and what your patient can tolerate. My surgery uses a brand called Hux D3. This is vegetarian and suitable for the vast majority of patients, and at the time of filming is also the cheapest preparation. For patients who can only tolerate liquids, we use a high-strength preparation called Invita D3. It's been a while since I reviewed the prices of these liquid formulations, so if you have a better one, please let me know in the comments. Every patient needs to have a calcium check 1 month after completing their 7-week loading regime, and this is to pick up any unmasked hyperparathyroidism. This is really important as this condition is often missed, so make sure you put a recall in place for a bone profile check. PTH testing is expensive, so you don't need to specifically request this, and the labs will add it if required. Now that we're happy with the adult loading, we can look at the regimes for children from NICE, which are very different. The total colecalciferol dose is far higher for children. Initially, I actually thought this was a typo, but when you think about it, children are going through massive amounts of bone growth, and children also have very little fat reserves to store the vitamin D. So it really makes sense that you need to give a child a much bigger loading dose than a fully grown adult. These regimes are based on evidence gathered from all over the world, but unfortunately, it all becomes a bit tricky when we realise there aren't really any formulations readily available in the UK to achieve these loading regimes. This often leads clinicians to improvise doses, creating regimes that might be ineffective or difficult for children to take, putting them at risk of harm as a result. So this is obviously really concerning, so what can we do in general practice to avoid it? Thankfully, the brilliant paediatric endocrinology team at the Great Ormond Street Hospital have put together some in-house guidance on this, which will hopefully stop you ever making mistakes with this again. If it's all possible, we should use the regimes from the NICE CKS, and please check with your surgery if they're happy with you using this guidance before you prescribe with it. But as you can see in their table, they offer a once-weekly alternative to the daily doses recommended by NICE. This means the 6,000 unit a day dose for 6 months to 12-year-olds can be converted to a weekly dose of 20 to 40,000 units, and the 10,000 unit a day regime for over 12s can be converted to a 40 to 70,000 unit a week dose, depending on your preferred formulation. I rarely, if ever, use the single stat dose to correct vitamin D, so I would only advocate this if it's been specifically recommended by your local paediatric or endocrinology service. So there you have it. Loading regimes for vitamin D in children aren't so difficult after all. See you next time.